Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 276 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, BUD is an 83-year-old woman with a past medical history of hypertension, osteoporosis, and hypothyroidism. Her present medications are levothyroxine 100 mcg daily, alendronate 70 mg weekly, vitamin D 800 international units daily, and calcium carbonate 600 mg twice daily. She has been diagnosed with hypertension for 2 years, and it has been treated with lifestyle modifications, that is, sodium restriction and exercise 3 times weekly. BUD is 64 inches tall and weighs 55 kg. Her current BP is 160 systolic 78 diastolic. It was 160 systolic 80 diastolic when repeated. All serum laboratory tests are normal. Her provider has been reluctant to start antihypertensive drug therapy because of BUD's age. How is treatment of BUD's hypertension different from that of a younger patient? Older patients with hypertension, that is older than 65 years of age, have the lowest rates of BP control, and this rate decreases in even older populations. Very elderly patients like BUD, similar to black patients, respond best to thiazides and calcium channel blockers and less to ACE inhibitors, angiotensin II receptor blockers, and beta blockers when these are used as monotherapy. However, it is unclear whether these small differences in BP lowering among classes are clinically significant, thus they are all recommended as first choice per JNC8 guidelines. We will now briefly discuss isolated systolic hypertension. BUD has isolated systolic hypertension, abbreviated as ISH, which is defined as an elevated SBP with a normal DBP. This pattern of hypertension is most common in older patients and incurs a significant risk for cardiovascular disease. It was once thought that patients with isolated systolic hypertension required high SBP to ensure normal perfusion of the heart and brain, and that treating ISH would further lower DBP and worsen organ perfusion. Evidence clearly demonstrates, however, that treating isolated systolic hypertension with antihypertensive drug therapy reduces the risk of cardiovascular events. BUD's hypertension should be managed with drug therapy in addition to lifestyle modifications. The next question reads, what data support antihypertensive drug therapy in patients who are very elderly, similar to BUD? The care of patients with isolated systolic hypertension, including the very elderly, should follow the same general hypertension care principles that apply to all patients, with 2 exceptions. The first is that the BP goal is different. JNC8 guideline recommends that BP goal of patients 60 years or older be less than that of 70 years. Their BP goal would be similar to younger patient population, less than 140 systolic, 90 diastolic. The second exception is that lower doses should be used when first starting therapy because of higher risk of developing orthostatic hypotension. Orthostatic hypotension occurs when standing upright results in an SBP decrease of more than 20 mm of mercury, or a DBP decrease of more than 10 mm of mercury after 3 minutes of standing and is often accompanied by dizziness or fainting. This is a risk of rapid BP lowering. Orthostatic hypotension is more frequent in elderly patients, especially those with isolated systolic hypertension, diabetes, autonomic dysfunction, volume depletion, and in patients taking certain drugs, i.e., diuretics, nitrates, alpha blockers, psychotropic agents, and phosphodiesterase inhibitors. Antihypertensive dose increases should be gradual to minimize the risk of hypotension. Moreover, initial therapy with 2 drugs should probably be avoided in the elderly, age 80 years or older, owing to the increased risk of orthostatic hypotension. The very elderly, i.e., patients 80 years or older, have traditionally been underrepresented in landmark placebo-controlled clinical trials. However, the HYVET was a placebo-controlled, randomized trial evaluating the effect of antihypertensive pharmacotherapy ACE inhibitors with or without a thiazide-like diuretic in patients with hypertension aged 80 years and older. This trial was stopped prematurely, after 1.8 median years, owing to a significant reduction in overall mortality in the treatment arm. The HYVET provides compelling evidence that treatment of hypertension in the very elderly provides significant benefits. BUD should be started on a low-dose thiazide diuretic or calcium channel blocker for the treatment of her hypertension. For elderly patients with existing incontinence, diuretic therapy will be problematic. Under this circumstance, a calcium channel blocker would be a more reasonable first-line option. Considering her advanced age, starting with monotherapy is appropriate to reduce her risk of orthostatic hypotension. The next question reads, you are developing a collaborative drug therapy management, abbreviated as CDTM, protocol for treatment of hypertension that will be used by clinical pharmacists. In your CDTM protocol, you include multiple pharmacotherapy options, ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, and thiazide diuretics, as equally recommended in primary prevention patients. However, you wish to include additional guidance on how to select an individual drug class to treat hypertension. What additional factors should be considered in your protocol when selecting a first-line agent for a specific primary prevention patient? It cannot be emphasized enough that selecting pharmacotherapy should follow an evidence-based philosophy. In patients with other comorbidities, certain antihypertensive drug classes are recommended in place of other options. In patients without other comorbidities, factors such as concomitant diseases, medication costs, serum electrolytes, and prior medication intolerances should be considered. These are helpful when selecting initial therapy for a primary prevention patient who has more than one acceptable drug class as a first-line option, or when selecting add-on therapy to further lower BP. The costs of treating hypertension and related complications are substantial to patients and health systems. With expanding availability of generic agents, costs attributed to drug acquisition are small in comparison with expenses for laboratory evaluations, office visits, and medical care for hypertension-associated complications. Whenever possible, affordable regimens that do not compromise efficacy should be designed. Generic antihypertensive products are equally effective and less expensive than brand-name products, and all first- and second-line antihypertensive classes have generic alternatives. The frequency of administration can influence treatment. Once daily administration assists adherence, all major drug classes contain agents that are either naturally long-acting or formulated in long-acting preparations. The next question reads, in your CDTM protocol, when should an ACE inhibitor or angiotensin II receptor blocker be identified as first-line therapy ahead of other antihypertensive agents? Unlike previous editions of JNC guidelines, JNC8 guidelines did not specifically discuss how hypertension treatment should be managed in patients with other comorbidities besides diabetes and chronic kidney disease. However, there are other coexisting diseases or hypertension-associated complications in patients which may warrant the use of certain classes of antihypertensive because these agents show significant benefits in reducing cardiovascular morbidity or mortality in patients with those specific comorbidities. Regarding diabetes, kidney disease and cardiovascular disease are both long-term hypertension-associated complications that are at high risk of occurring in patients with diabetes. JNC8 recommends the same four classes of antihypertensive agents as first choice in non-Black patients with diabetes for primary prevention of cardiovascular events: ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, and thiazide diuretics, and calcium channel blockers in Black patients. When compared head-to-head, ACE inhibitors are superior to dihydropyridine calcium channel blockers at reducing cardiovascular events. Subgroup analyses of larger clinical trials further support cardiovascular event reduction with ACE inhibitors and angiotensin II receptor blockers. Therefore, ACE inhibitor and angiotensin II receptor blocker may be preferred initial antihypertensive therapy for a patient with diabetes if there is no other contraindication. The next question reads, in your CDTM protocol, how should significant chronic kidney disease be defined so that patients with chronic kidney disease can be identified and treated appropriately? Next we will look at chronic kidney disease. It is common that chronic kidney disease presents initially with microalbuminuria, 30 to 299 mg albumin in a 24-hour urine collection, that can progress over the course of several years to overt kidney failure. Progression is accelerated in the presence of both hypertension and diabetes. JNC8 recommends ACE inhibitor or angiotensin II receptor blocker therapy to be used as first-line therapy in chronic kidney disease patients because both have been shown to reduce the progression of chronic kidney disease in type 1 diabetes, in type 2 diabetes mellitus, and in those without diabetes. Recently, angiotensin II receptor blockers therapy has also been shown to decrease risk of developing microalbuminuria in patients with diabetes mellitus. Although many of the long-term benefits of ACE inhibitor or angiotensin II receptor blockers therapy may be from BP lowering, their evidence base is robust enough to support their first-line use in chronic kidney disease. After ACE inhibitor or angiotensin II receptor blockers therapy has been implemented, data support a calcium channel blocker as the second drug because this has been shown to reduce progression of chronic kidney disease better than a thiazide diuretic as the second drug added based on the avoiding cardiovascular events through combination therapy in patients living with systolic hypertension, abbreviated as the ACCOMPLISH trial. Next we will look at chronic kidney disease. It is common that chronic kidney disease presents initially with microalbuminuria, 30 to 299 mg albumin in a 24-hour urine collection, that can progress over the course of several years to overt kidney failure. Progression is accelerated in the presence of both hypertension and diabetes. JNCH recommends ACE inhibitor or angiotensin II receptor blocker therapy to be used as first-line therapy in chronic kidney disease patients because both have been shown to reduce the progression of chronic kidney disease in type 1 diabetes, in type 2 diabetes mellitus, and in those without diabetes. Recently, angiotensin II receptor blockers therapy has also been shown to decrease risk of developing microalbuminuria in patients with diabetes mellitus. Although many of the long-term benefits of ACE inhibitor or angiotensin II receptor blockers therapy may be from BP lowering, their evidence base is robust enough to support their first-line use in chronic kidney disease. After ACE inhibitor or angiotensin II receptor blockers therapy has been implemented, data support a calcium channel blocker as the second drug because this has been shown to reduce progression of chronic kidney disease better than a thiazide diuretic as the second drug added based on the avoiding cardiovascular events through combination therapy in patients living with systolic hypertension, abbreviated as the ACCOMPLISH trial. The next question reads, in your CDTM protocol, although beta blocker is no longer considered as a first choice for primary prevention, are there any cases when beta blocker therapy would be identified as an appropriate first-line antihypertensive drug therapy? Next we will look at chronic and acute coronary artery disease. The American College of Cardiology (ACC/AHA) have guidelines for chronic coronary artery disease that recommend treatment with a beta blocker, followed shortly thereafter by the addition of an ACE inhibitor. Beta blockers, those without intrinsic sympathomimetic activity abbreviated as ISA, decrease the risk of a subsequent MI or sudden cardiac death by decreasing the adrenergic burden on the heart, and progression of coronary atherosclerosis. ACE inhibitor therapy promotes cardiac remodeling, improves cardiac function, and reduces the risk of cardiovascular events. An angiotensin II receptor blocker is an alternative in patients who do not tolerate an ACE inhibitor, because fewer data exist that assess the long-term impact of an angiotensin II receptor blocker on cardiovascular events compared with an ACEI in chronic coronary artery disease. A thiazide diuretic can be added to the core regimen of a beta blocker with an ACE inhibitor, or angiotensin II receptor blocker, if additional BP reduction is needed. However, if an additional agent is needed to treat ischemic symptoms for patients with chronic stable angina, a dihydropyridine CCB can be added to this core regimen. If a beta blocker cannot be used because of intolerance or contraindication, a non-dihydropyridine calcium channel blocker can be used as an alternative to a beta blocker. Acute coronary artery disease, also called acute coronary syndrome, includes unstable angina, non-ST segment elevation MI, and ST segment elevation MI. The ACC/AHA guidelines for these conditions indicate a beta blocker as first-line pharmacotherapy. Let's look at left ventricular dysfunction. Pharmacotherapy for left ventricular dysfunction should include a 3-drug combination of an ACE inhibitor, a beta blocker, and an aldosterone antagonist, plus loop diuretics depending on the need for diuresis. ACE inhibitors, beta blocker, and aldosterone antagonists all have numerous landmark clinical trials showing reduced morbidity and mortality rates, whereas diuretics provide primarily symptomatic relief of edema. According to evidence-based medicine principles, only metoprolol, carvedilol, and bisoprolol are indicated for left ventricular dysfunction. Other beta blockers, e.g., atenolol, should not be used in patients with left ventricular dysfunction because they do not have supporting data demonstrating they reduce cardiovascular event rates in these patients. Patients should be clinically euvolemic and hemodynamically stable before adding a beta blocker. It is important to start with very low doses of a beta blocker, then slowly titrate upward over the course of several weeks to the recommended dosing range for left ventricular dysfunction. An angiotensin II receptor blocker can be used as an alternative to an ACE inhibitor. Potassium serum concentrations must be carefully monitored in the situation when ACE inhibitor or angiotensin II receptor blocker and aldosterone antagonist are used together. Alternatively, the combination of hydralazine with isosorbide dinitrate can be added in black patients. This combination has been demonstrated to improve cardiovascular outcome in this patient population. We will now look at monitoring therapy. 4 aspects of treatment must always be considered. A. BP response to attain goal. B. Adherence with lifestyle modifications and pharmacotherapy. C. Progression to hypertension-associated complications. And D. Drug-related toxicity. Reduction in BP should be evaluated 1 to 4 weeks after starting or modifying therapy for most patients. BP usually begins to decrease within 1 to 2 weeks of starting an agent, but steady-state antihypertensive effects can take up to 4 weeks. If patients are in hypertensive crisis, evaluation should occur sooner, within hours to days. 2 BP values separated by at least 1 minute should be measured during each clinical evaluation, with the average used to make a proper assessment. If dehydration or orthostatic hypotension is suspected, BP should be measured in both the seated and standing positions to detect orthostatic changes. For routine monitoring, measuring BP in the seated position is sufficient. Self-BP monitoring values should be considered if available. Normally, however, they are slightly lower, that is by 5 mm of mercury, than clinical values even in patients without white coat hypertension. For example, patients with a goal BP value of less than 140 systolic 90 diastolic should have home measurements that are less than 135 systolic 85 diastolic. All patients should be questioned in a non-threatening manner regarding adherence with lifestyle modifications and drug therapy. This is especially important for complex regimens when drug intolerance is likely, or when financial constraints hinder acquisition of medications. Evaluating hypertension-associated complications and drug side effects are essential. New hypertension-associated complications may necessitate changes to treat a compelling indication or attain a new BP goal. Drug-related side effects may similarly require therapy modifications. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 277.